Thank you, sir. So I'm going to be talking about the current guidelines in the Indian context. Slides. Okay. These are the heads that we're going to cover, but let's go directly into it. So the Indian problem is like probably the largest in the world. We have the highest number of preterm babies in any country, more than twice that of China. That's about 35 lakh babies. Now, if you extrapolate that to the number of specialists that we have, the IROP Society conducted a survey sometime, and we have about less than 200 members, out of which less than 100 are comfortable doing the laser therapy. So yes, there is a big demand-supply gap, and that's Government of India data extrapolated that every 2 hours somewhere, 3 babies in India are going to require treatment. Why do we have such a big problem? This has been discussed in an editorial. High levels of prematurity, better survival, not so much awareness, oxygen blenders absent, and even among the pediatric community, there is a lot of gap. Now, that's therefore the need to have a national screening guidelines. It started off in 2010 now, about 13 years back. There was some confusion in this about babies between 1750 and 2000 grams. And that problem was set right in the operational guidelines by RBSK in 2017, 2018. And then from there, it was culled out the operational guidelines for ROP itself. So the picture on your left is the RBSK for universal screening with ROP as a chapter, and then the operational guidelines on the right. And this is what I'm going to deliberate now. And then this has been tested in the community to see how it can work. This is a great take-home point to teach our pediatrician friends, the 1, 2, 3, 4 rule, which is the first screening should be done for babies born less than 2 kg. So that's the 2 and less than 34 weeks. So it's rather simple now that 1750 and 2000 has gone away. So which infants need to be screened are important. But since gestational age is a little difficult to assess sometimes in our rural babies, birth weight is a very important parameter. So if you know the gestational age, then it's 34. Otherwise, any baby born less than 2 kgs. It doesn't matter if it's an IUGR baby, less than 2 kgs. From a government point of view, from a guideline point of view, easy to manage. Before discharge or once before 30 days of life. So that's the slogan, 30 din roshni ke. So don't delay the first screening for 30 days, before the 30 days of life. Why before discharge? Because on the average, the NICU stay is about 7 to 12 days. And therefore, expecting the mother to come back between week 3 and week 4, the follow-up can be lost. We showed that in this study, 2 government hospitals. The follow-up was 12 times more if we screened once before discharge. So it's okay if the baby is few days old, do the first screening, the subsequent follow-up can be done at the right time, which means 3 to 4 weeks later. Now, this is the clinical and the legal caveat, 30 days. Don't wait for the baby to become systemically all right. As Dr. Dogra's group has shown, you can treat these babies through a scratched incubator wall. So when you can treat these babies, why can't you screen them? So convince your neonatologist that this is the sickest babies who have the worst ROP, and don't delay the screening. Indirect ophthalmoscopy, I would say, dare to say, used to be the gold standard. Nowadays with imaging, maybe that's changing. But for the majority, indirect ophthalmoscopy is what can be done. You can turn the baby, you can move around the table, you can do it in the NICU, face the quadrant that you want to examine. These are some of the instruments that we've brought down to low cost, which are available, but otherwise the traditional equipment is used. We are possibly the first country in the world to allow wide field imaging as a accepted methodology for ROP screening, and that too by non-physicians, that is by nurses, optometrists, imaging specialists. Of course, they have to be certified. So that's where this is. You don't have to be a doctor to screen. You can be a trained technician. This is the Make in India camera, which now has more than 400 installations and FDA and CE approval. I have no financial interest in it, but I was the PI for testing it in the community. And this is now, they are coming out with their angiography unit as well. When do you discharge a baby from screening? Even more important than when you start screening. It's a legal problem. So one should not discharge a baby less than 40 weeks of postmenstrual age, because that's when the vessels should have reached the temporal ora serrata. So if you're seeing a baby at 36, 37 weeks and doesn't have ROP, repeat an exam at least 4 weeks later between 40 and 45. Or of course, if you have a doubt, then just repeat an exam. 2 exams between 2 weeks saying that there's no disease with the vessels reaching at least zone 3 or 1 disc diameter from the aura is good enough. So when you look at an image, when you look at a baby, the diagnosis can be either completely normal, requires treatment, or needs follow-up. So if you have that in mind, that's the triage that you can train anyone to do either reading as far as reporting of images are concerned, or you can do it when you're doing the indirect ophthalmoscopy. The best way to document it is to also hand over an ROP card to the mother where you've written out which day, what time, and the venue for the next follow-up. These are all very important caveats from a legal point of view. And of course, if you have imaging, then there is what to do. This our wide field imaging program, the KidROP, has been evaluated in terms of the UNDP and the CDC. And this is just one leaf from that report, which says that if you do indirect ophthalmoscopy without proper training and you might miss the findings, it can be a medico-legal problem. Now, the Indian context to the ICROP3 classification, two of us from India represented the country in the classification. I'm only going to tell you how it is, how we've added and why it's important to us. So aggressive posterior ROP has now gone away, and we now call it aggressive ROP. So clearly we've dropped the word posterior, which means that, and as you can see here, even anterior disease, which otherwise looks like, hey, vascularization going up to the zone 3, can be very ominous and sinister. Look at this capillary non-perfusion in angiogram, and look at the RETCAM picture here. Doesn't look so bad, but these are the cases that often get misdiagnosed, underdiagnosed, and these can be the worst nightmare. Two more terms were added, regression and reactivation. So regression, incomplete regression, is really important. We've added a new term called persistent avascular retina. It's at least 2 disc diameters of the peripheral retina that has not received the blood supply. Very important in babies who've been injected. And reactivation, as the word suggests, it will come back. And the comeback pattern can either be vascular, can be a ridge, can be both. Can be in the old disease space, can be in a new area, can be in both. Which basically means anything can happen, and it could be a regression, a reactivation. So one has to keep out, watch for it. Medico-legal, unfortunately, the ugly head has shown. 2015 landmark judgment, July 1st, 1.8 crores, 11 cases after that, including one this year in Rajkot. So what have we learned from it? Well, we've tried to summarize it in this publication. It's free for download, where we've tried to look at how we can mitigate, reduce the incidence of litigation against doctors. Out of all those 11 cases, 10 of them went against the pediatrician, one went against the ophthalmologist and the doctor and the pediatrician. So it's really important not to scare our colleagues in neonatology, but at least to make them aware that this is a serious problem. In terms of technology, I just want to show you that this is now the angio device of the Neo. We've just completed the clinical trial in the NICU. This is just to show you that it's portable and it's doable. With more and more anti-VEGF being used, FFA seems to be an important tool on how we'll evaluate these babies. We were also the first society in the world to come up with ROP guidelines during the COVID pandemic. It came out as early as March 30th, 2020, and much before social distancing became a thing. We decided, okay, now I'm not able to move my slides. Sorry. Yeah. Okay. So, and basically, what did we change? And I think we've seen the back of the pandemic, but what's really important here is that we did allow some gray area and how early we can treat. And those who are not comfortable with laser, we said, go ahead, do the injection, and then refer to a place where laser and follow-up can be done. This is a colleague and me trying to laser a COVID positive baby in April 2020 when we had no clue what to do. Sir wanted me to cover a bit of the AI. So in terms of predicting ROP, there's some very exciting work we're doing in Bangalore. We are now able to take the tears of these babies and looking at the family of proteins that we get in the first screening, we're able to now predict which baby will eventually get the disease. We are not yet quite at the point where we can predict when that disease and whether it will require treatment or not. The first publication is in IOVS. The second one is coming up shortly. And artificial intelligence. As cost of cameras go down, more and more images go up, it kind of makes intuitive sense that we may need AI algorithms. So this is some work we've been doing. There are other groups, both Dr. Sucheta Kulkarni's group in Pune and Parag's group in Arvind are also collaborating. So here are algorithms that take the worst images, pick out the best features, and help us make a diagnosis. So that's to summarize what work it is. But AI will really work only when we can integrate it into an imaging telemedicine program. And this is one of the more recent publications that we did cross-authorship across many of the centers that you see here. And this one is a standalone PhD that came out of Chennai, where we are now able to have about a 92% accuracy on whether the image has stage 2 or stage 3. So that's what you're seeing on your left and on your right. So it's early years. It's about 90%. It's good. It's not awesome. It's work in progress. And it has to be camera agnostic so that we should be able to use it both on the RETCAM, the NEO, and any other new camera that may come. So I'm going to conclude my talk here. I'd like to thank all our collaborators, beginning with Government of India, and thank you so much for being a patient audience.